Okay, Dr. Santosh, please start.
Yeah, thank you, ma'am. Good morning, ladies and gentlemen. So we generally come across these type of cases which have multiple injuries, anterior as well as posterior segment trauma, very badly mutilated eyes following severe trauma. Though in these cases the patient have very poor visual prognosis. So one option in these cases is that you don't do anything because generally the vision is very poor, PL positive, PL negative. But another thing is that if you can go ahead and do surgery so that the patient at least has some ambulatory vision. So this idea came somewhere in, go back to history in 1981, when the Landers first started his temporary keratoprosthesis, which he used, which was the bioconcave cylinder made of PMMA, which was later modified by ICARDS in 1987. So basically, there's two types of keratoprosthesis were existing. The one was Landers, and the second was ICARD, with some difference in between. The Landers was made of PMMA, ICARD was silicone rubber. They had some few advantages, like the Landers had were made of PMMA, so the replacement was not required. But the disadvantage he had, that because of long cylinder, the posterior segment view was not easily seen. ICARD had advantage of excellent view of posterior segments, so that the patient, at least the retinal surgeon, can perform surgery easily. But because it was made of silicone rubber, so it was getting easily damaged. So in our series, we just did the retrospective review of cases for last 2 years, which had undergone temporary K-Pro-assisted vitreoretinal surgery, followed by penetrating keratoplasty. Essentially, the procedure consisted of, because this surgery used to last for long, 3 to 4 hours, 5 hours. So all surgeries were done under general anesthesia. The procedure started with the fixing of infusion cannula and other cannula for the VR surgeon. Then the corneal refining was done. Generally, we used Indian-made keratoprosthesis, temporary keratoprosthesis of size of 7.5. After corneal refining, the temporary keratoprosthesis was fixed to the globe using Vicryl 60 or 70 suture. After fixing, the VR surgery was done, and at the end, under the silicone oil, the penetrating keratoplasty was done. So we reviewed the case of 6 patients, and the primary outcome was how the visual gain was following surgery. So this is a list of 6 patients we had. All 6 patients have most of related to trauma, with initial very bad visual prognosis and visual acuity of PL plus, PR inaccurate. But at the end of all this, they at least had some good useful vision, lasting from 1/60 to 2/60. Most of the cases, the retina was attached, but the problem was because of graft failure and secondary glaucoma. Secondary glaucoma was most problematic for these cases. In cases of graft failure, we asked the patient to go for repeat surgery, but the patient denied. When we compared our study with the existing study, in their study also, they had 12 patients, we had only just 6 patients. Visual gain was similar to our case series. Vision improved in 7 eyes. They also had graft failure, that as a problem, and the retina was attached in 92% cases. So just to conclude, these cases pose various difficulties, but temporary keratoprosthesis VR surgery should be attempted in all cases, especially one-eyed cases of having severe trauma. They generally have anatomic stability, but poor visual gain because of other complications. And I would like to thank my colleagues, my team of corneal surgeons and VR surgeons for their contribution. Thank you.
Doctor, here.
Yes, sir.
Just the primary focus behind your particular paper is temporary keratoprosthesis. Does it help intraoperatively for your
the VR surgically, yes.
Injured patients?
Yes, sir.
So I don't find any discussions about intraoperative discomforts or adverse reactions. And as well, were there any cases which had post-operative phthisis?
Post of what, sir?
Phthisis, atrophic bulbi or phthisis bulbi?
No, in our series, no patient had.
Okay,
they still follows.
How did differ from keratoprosthesis, or what is the message you want to convey?
Message I want to convey that generally the tendency is that since they have very poor vision, the patient don't go ahead doing surgery, because first thing is the prognosis is very poor. Second thing is they have long surgery hours. So, but if the patient has, but the message is that this patient can also have useful, at least ambulatory vision at the end of surgery.
Okay.
Okay, thank you, Dr.
Thank you.
Santosh. Want to announce the next speaker? Can we have the next speaker, please? Dr. Pradeep Kumar. Is there? He's not there. Do we have Dr. Kruti Shroff? He's not there. We have Dr. Sudhir. Dr. Sudhir Rachapalli, he is going to talk to us on the impact of sustained gel drops on ocular surface kinetics of topical fluorescein. Wow.
Good morning, everyone. I'll be presenting to you on the impact of sustained gel drops on ocular surface kinetics of topical fluorescein. This was a part of an investigator-initiated grant from Alcon. To introduce, sustained gel is the new, when we want to have the drug for the dry eye for a longer duration, we need to have a mucus adhesive drops or a viscous agent which needs to be there in the eye for a longer time. Sustained gel has a polyethylene glycol, propylene glycol, HP, GOR and boric acid which helps in formation of a gel-like on the surface of the eye, and also has a demulcent qualities which will help to hold the water content for almost 10 times its volume. We used a custom-made spot fluorometer to measure the residence time of the drug using a fluorescein emission. Based on the, we used a spot fluorometer which has a LED light, and the emission light from the fluorescein is using a confocal method and using a photomultiplier tube, and with a lock-in amplifier we can be very accurate only capturing that particular wavelength of light. We can use this for measuring epithelial permeability, endothelial permeability and aqueous dynamics of the drug, and for the drug in the surface of the eye. So this was a study, a cross-sectional observational study on normal subjects. They were all ruled out of any ocular pathology. So the patients were instilled normal saline and with fluorescein, and it was measured how much time the fluorescein stays in the eye. And subsequently, maybe 1 hour later, or on a next day, the patient instilled cysteine gel along with fluorescein of 30 microliters, and the residence time of the fluorescein was measured. We also did independent measurements of tear meniscus height, tear breakup time using oculus keratograph, which is to correlate with these. So these are samples from the two patients, where we can see the blue line is the normal fluorescein in the normal saline. The decay time is measured, and this is for the cysteine gel. So these vibrations are because each time they blink, the cysteine gel, the fluorescein goes up and down, but we can look into this. The half-life of the normal saline was just 120 seconds, whereas the half-life of cysteine gel was almost 10 times, 1120 seconds. We also calculated the area under the curve, and the area under the curve will tell us how long the drug stays in the cell. So we can see it is almost significantly different, and it is almost 10 times the same time with the half-life of the drug in the ocular surface. When we looked at tear meniscus height, tear breakup time, there was not much of a difference. So when we only depend on ocular keratograph for measuring this, we may not actually give the how much time the drug stays in the eye. So to conclude, that the cysteine gel, which has a viscous and the mucoadhesive property, we need to have measurements for tear film, half-life of the drug and also the residence time. With using a photo multiplier tube with a lock-in amplifier, we can get accurate measurements, and this was almost 10 times than the normal drug. And whereas tear meniscus height and tear breakup time was not correlating much with the amount of time the drug stays in there. So we conclude that using spot fluorometer with appropriate clinical correlation parameters can assess the efficacy of various therapeutic agents for the treatment of dry eye, and Sustain Gel can be one of the drug which can stay in the eye for a longer time, can be one of the help in symptomatic treatment of patients with moderate and severe dry eye. Thank you.
Thank you, doctor. You showed that there is no effect on the tear breakup time at all?
Yeah, so when we compared with the normal saline, we measured it every 10 minutes to check. So the tear breakup time was not significantly different. It was almost same throughout the period. Whereas
Same
the tear,
as the normal saline, that sounds quite...
we also checked with the normal saline, so it was not showing much difference. So we were not sure whether the keratograph will not give you accurate measurements, that is one. Whereas when we actually look at the fluorescein, which is there in the mixed with the tear substitutes, then we can actually measure and see how long the drug stays in the eye. So that was one of the ways. So tear meniscus and tear breakup time may not be very correlating factors when we really want to measure the resident time of the drops in the eye. That's what we wanted to conclude.
Because we would imagine that it kind of improves the tear breakup time, right?
Yeah,
So that
but
I found quite a bit contradictory.
Yeah, that's what we wanted to bring it up.
So good on. Spot fluorometer, how long does the process of examination take?
Yeah, it takes almost, we have to be there for 1 hour because the drug stays. So we have to say from the baseline and how much time it takes to come back to the baseline. That is where we need to look at it. With spot fluorometer, I think we can be very, we can focus on the surface and get the, if you want to look at the drug penetration into epithelium, stroma, aqueous, we can even do that with that confocal focus.
Okay.
Thank you.
Thank you, doctor. Can we have our next speaker, Dr. Ashika Shah? Do we have her here? It's a male, sorry. Dr. Arvind Roy was just, he just spoke, is it? Yeah, it's all jump. Dr. Arvind Roy? Yes. No, they're asking us to follow this schedule.
Yeah.
Can we have the scoring sheet for the third judge, please?
Yes. So, a very good morning to all, and thank you for the opportunity to share our work. Our paper is on the spectrum of microbial keratitis during post-COVID convalescence. We report the clinical and demographic profile of microbial keratitis in patients who presented within 3 months of acute COVID-19 infection. We had 18 eyes of 16 patients with microbial keratitis during the post-COVID convalescence. 14 patients were unilateral. We had an IRB approval for the study. The presentation was between 1 to 93 days post-COVID. The risk factors were multiple. There were more than one risk factor in each patient, so the total would add up to be more than 18. However, the commonest was the hospitalization for COVID. In addition, there were comorbidities such as diabetes and hypertension. Oxygen administration and systemic steroids are also administered in 5 and 3 patients respectively. The microbes that we identified were equally divided between microsporidia and fungus, the other two being a case of pythium and herpes zoster. We managed these cases medically in 9, but therapeutic keratoplasty was required in 5 and tissue adhesives with bandage contact lens was administered in 2 patients. I will briefly run you through if 3 clinical scenarios. Number 1 was the microsporidia. Microsporidia keratoconjunctivitis is very common in our setup. However, what was different during COVID was that it had a component of anterior uveitis. So this was a young girl who was isolated with their parents, and the parents had COVID. This girl was not tested with COVID. Nonetheless, being in close proximity, this patient most likely had the symptoms of COVID and was treated as a COVID patient. And 2 weeks post the recovery, there was stuck-on lesions on the cornea. But what was special was that there was anterior uveitis and there was pseudogatati on the cornea, which resolved with fluorometholone after the corneal lesions resolved. This was a second case of an atypical fungal keratitis. So this patient was hospitalized, there was neurotrophic keratitis, exposure keratopathy, and post-infection, the patient after hospitalization of 5 days presented with a neurotrophic keratitis and a secondary fungal infection. So in addition to antifungal, this patient also required tarsorrhaphy and amniotic membrane graft. This was a third patient of redness, watering and swelling, and this patient had herpes zoster sign herpes. He was hospitalized 3 weeks earlier and was on IV steroids. Oral acyclovir 800 milligram helped with resolution of this condition. So perhaps these are patients of long COVID, which is a symptoms of COVID within 2 months of convalescence. And these patients had a dropout of the nerve vessels as was shown in this study. So perhaps there is a decrease in the nerve density and increase in dendritic cells. And though we cannot particularly suggest a causal association, but there might be a temporal association with COVID convalescence, and altered immune response leads to this altered manipulation. So thank you very much. I would like to acknowledge the help of colleagues and fellows who helped in collate all this data. Thank you.
Good. One thing, what was the mean time between the COVID and presentations?
Typically, we saw them within 3 months. The range was 1 to 93 days, but majority of the patients were within 2 weeks to 4 weeks of the post-COVID convalescence.
And it's interesting, no bacterial keratitis.
Yes, that was something which is very surprising. And in our part of the country, microsporidia keratoconjunctivitis is very common. There are a series of publications. But microsporidia keratoconjunctivitis, unlike the adenoviral keratoconjunctivitis, is typically a stuck-on lesion on the cornea, and the anterior segment is absolutely normal. Whereas the COVID patients typically had a component of anterior segment inflammation. And these were PCR positive microsporidia, meaning that we thought that we could be mistaken. So what we did was that we scraped and then subjected this to pan microsporidia RNA and also the adenoviral DNA, and it came to be positive for PCR.
Because there are a lot of reports also.
Yes.
COVID virus also breaks down blood aqueous barrier.
Absolutely,
That's the reason.
Certainly, this is the interesting thing about the study.
All right.
Yeah, I think very interesting. As you yourself pointed in your last slide that the causal association, it's difficult to prove that. The fact that it's bilateral, of course for microsporidiosis that's pretty common, but for fungal keratitis to get that bilateral,
Yes.
it is very uncommon. So
Indeed.
yeah,
Indeed.
yeah, it's quite a good presentation. Thank you.
Thank you very much.
Can we have the next speaker, Dr. Sunita Pandey? She's presenting on the clinico-histopathological features and outcomes of keratoplasty in xeroderma pigmentosum. Oh, that's a good topic.
Good morning to one and all. Uh, my topic is on xeroderma pigmentosum, its clinical presentation and histopathological correlation. Xeroderma pigmentosum, as we all know, is a rare genetic disorder and characterized by solar injury to the exposed skin and ocular tissues, autosomal recessive in inheritance pattern. The defect is due to the enzymatic repair in UV-induced damage in DNA. The ocular manifestations include eyelids, conjunctiva, sclera, and cornea and xeroderma. Corneal involvement is mainly in the form of dryness, haze, edema, exposure keratitis, pterygium-like growths, and epithelium neoplasms. Corneal opacification may result in XP from epithelial stromal changes or secondary to endothelial decompensation as a result of ongoing damage. The need for visual rehabilitation is XP mostly is due to corneal involvement, and intervention can be required in the form of penetrating keratoplasty or lamellar keratoplasty. Eventually, keratoprosthesis can also be of great help in single-eyed patients. There are few reports describing the histological corneal changes also in xeroderma pigmentation already reported before, and it can range from epithelium to endothelium involving all the layers of cornea. The purpose of our study was to review clinical and histopathological examination findings in xeroderma pigmentosa patients undergoing corneal transplantations. It was a retrospective and interventional analysis, and we assessed clinical findings and outcome of keratoplasty along with histopathological findings from the button excised. There were total 14 eyes of 11 patients, out of which 11 patients underwent penetrating keratoplasty and 3 underwent lamellar keratoplasty. Patients included from 1999 to 2019. The mean age at surgery was 21.4 with male preponderance. Male to female ratio was 5:1. 11 patients underwent penetrating keratoplasty and 3 lamellar, out of which 9 patients underwent it for maculoleucomatous corneal scarring, followed by epithelial neoplasm in 4 patients, and 1 patient presented with descemetocele. Lamellar keratoplasty in 3 patients was mainly indicated for surface tumors, OSSN, and penetrating keratoplasty was done for maculoleucomatous vascularized opacity. We noticed 5 graft failures, out of which 4 was in penetrating group at mean duration of 14 months. And clear grafts was noticed in almost 60% of the patients with mean follow-up of 5 years. This was one 14-year-old female patient who had both eyes maculoleucomatous opacities, and she is doing well now at 5 years of follow-up with BCU maintaining more than 6/5/15 in her right eye. This was another patient who underwent lamellar keratoplasty for squamous cell carcinoma. It was microinvasive, and post-excision the graft failed. Histopathological changes included all the layers, in which epithelium was involved in 80% of the patients in the form of thin and atrophic keratinized epithelium. Bowman's layer was noted to have absent to focally deficient. Almost 100% patients had endothelium loss. This is a histopathological slide in dysplastic cell carcinoma. So in all other literature reported before, we had the similar findings with 100% endothelium involvement. The Kanavi et al., they also noted cholesterol collapse along with above mentioned features. So to conclude, better outcome of keratoplasty in XP is possible despite ocular surface and adnexal complexities. Endothelial cell loss forms the hallmark of histopathological change and hence important in planning type of surgery also. Close monitoring as usual is crucial. Thank you.
Any specific post-operative regimen do you follow with medications?
No, sir, we follow the topical and lot of lubricants we follow, sir, because these patients will be having some or the other amount of limbal stem cell deficiencies. Because of lid-related issues, the patients would be having exposure keratitis, some ectropion and all. So lubricants, they help a lot. Also, in some patients, we might need to do tarsorrhaphy for better surface healing, sir.
So tarsorrhaphy was done in any of your
Yes, ma'am. It was done in almost 3 to 4 patients. Actually, the study is till 2019. After that also, one patient underwent keratoprosthesis with lateral tarsorrhaphy.
And what was the reason for graft failure in your series?
Ma'am, in 3 patients, it was patient had gross ectropion and also there was eventual surface-related issues with total LACD. And other patient, ma'am, surfaced this lamellar keratoplasty. One patient underwent for squamous cell carcinoma. There was recurrence of carcinoma also, ma'am.
What were your visual results?
Ma'am, it was
the
in
percentage of grafts that stayed clear and
60% of the patient had clear grafts, ma'am, at 5 years of follow-up.
So what was the
with
vision?
more than 6/60 of vision they were maintaining, ma'am.
Thank you.
Okay, thank you.
Can we have the next speaker, Dr. Svikriti Jena? It's all ulta, no? Confusing. Where is this? She's presenting on smaller versus larger, which is better for therapeutic penetrating keratoplasty and microbial keratitis.
Good morning, everyone. My topic is smaller versus larger, which is better for therapeutic penetrating keratoplasty and microbial keratitis. I have no financial disclosure. Introduction: microbial keratitis is an important cause of corneal blindness in India. The infection usually occurs following ocular trauma and contamination of corneal lesion. Microbial keratitis is often difficult to manage with medical therapy alone. The important reason for poor response to medical therapy is the delay in diagnosis and lapse in early institution of the therapy. Hence, therapeutic penetrating keratoplasty is required in cases where topical medication failed to eradicate the infection. The success of keratoplasty in the active stage of infection has several limitations. An important cause for failure of keratoplasty is the recurrence of infection after surgery, with reported rates ranging from 5 to 14%. The purpose of the present study was to analyze the outcomes of therapeutic penetrating keratoplasty performed consecutively for non-responding fungal keratitis. The aim is to compare the outcome and results of therapeutic penetrating keratoplasty using larger donor grafts of size more than 8.5 mm versus smaller grafts size of less than 8.5 in patients with recalcitrant microbial keratitis in a tertiary care center. Materials and methods: it's a retrospective study, time period from June 2019 to May 2020. A cohort of 20 eyes of 20 patients that underwent therapeutic penetrating keratoplasty with a graft size of more than 8.5 mm was compared with 20 eyes of 20 patients undergoing therapeutic PK with graft size of less than 8.5 mm. The medical records were reviewed thoroughly for the demographic details, risk factors, size of ulcer, microbial investigations, donor graft size, post-op complication, and anatomical and visual outcomes. These are the few pre-operative photographs of the patients with microbial keratitis. And this is the post-op after undergoing therapeutic PK. We can see the first picture, the graft is clear. This is 1 year post follow-up therapeutic PK. We can see the clear graft. Results: both cohorts were comparable for age, sex, and ethnicity. Age of patients ranged from 16 to 60 years, and average follow-up period was 1 year. The anatomical integrity was achieved in all patients. The preoperative visual acuity ranged from PL to 6/60, and post-op VA remained same in 23 patients. It improved to less than 6/60 in 7 patients and was more than 6/60 in about 10 patients. In the first cohort, that is a graft size of more than 8.5 mm, in 14 patients the graft was clear. 2 patients had graft failure, 2 had infection, 1 had wound leak, and 1 patient had wound dehiscence, and 3 patients developed secondary glaucoma. In the cohort of graft size less than 8.5 mm, in 8 patients the graft was clear. 5 patients had graft failure, 4 had infection, 2 of them had weak, and 1 patient had wound dehiscence, and 1 patient developed secondary glaucoma. Now here is we can see that in graft size of more than 8.5 mm, the proportion of patients having a clear graft is more than the cohort having graft size of less than 8.5 mm, but the chances of secondary glaucoma is, here 3 patients had secondary glaucoma in smaller graft size as compared to the 1 patient with secondary glaucoma in graft size of more than 8.5. So the larger donor grafts, conclusion: larger donor graft has better functional outcome in patients with microbial keratitis undergoing therapeutic PK as compared to smaller grafts, except for secondary glaucoma, which was more common with larger grafts. Therapeutic PK has a definitive role in management of severe keratitis, with huge success in restoring anatomical integrity and providing useful vision. Thank you.
How many of the patients had bacterial and how many were fungal, and the patients undergoing keratoplasty?
Ma'am,
How many were bacterial, how many were fungal?
Ma'am, most of them were bacterial and like second combination.
And did the post-operative regimen differ in the patients? what did you give them?
We've given immunosuppressant drop, cyclosporin drop was given, and then antibiotic, and fungal cases we've given natamycin drop and
Fungal cases
natamycin eye drop we've given.
where steroids started at some point.
Yeah, steroid drop, prednisolone drop.
So what is your protocol of starting steroids for fungal keratitis, therapeutic PKs operated for fungal keratitis?
In fungal keratitis, we are not giving immediately a post-op, we are not giving a steroid drop. In bacterial, we've given prednisolone drops.
So I feel basically the etiology would also make a difference in the graft outcome, because obviously fungal, if they are associated with perforation or impending perforation and lot of infiltrates and inflammation, they are likely to do much worse related to the etiology. Similarly, virulent bacterial like Pseudomonas or against with perforated ulcers, they are likely to do much worse than the other ones. So not only it depends on the graft size, it depends on several other factors also. Yeah.
I just have one quick question for you. It's a retrospective analysis. How did you work on the sampling of 20 each?
We have taken from the the data itself.
It is just like that, or you planned for 20 only?
We've taken a planned for 20.
Thank you.
Thank you.
She was Aditi? She was Aditi, right? Yeah, she was not Aditi. Can we have the next speaker, Dr. Aditi Madkaikar? She was Vikruti. Her paper is on the COVID-19 impact on eye donations and corneal transplantation, her experience.
Good morning, everyone. Mine will be a brief discussion on the impact of COVID-19 on eye donations and corneal transplantation. There was an overall decrease in the eye donation in the COVID period, which was a 63% decline, and the total corneal transplantation reduced to a 52% drop in the COVID period. So we conducted a retrospective study on the donor and recipient records stored in the Rotary Eye Bank of Arvind Eye Hospital from the period of January 2020 to May 2021. The data was analyzed separately for donors and recipients. Whole globe donor retrievals were done from the Hospital Corneal Retrieval Program through a grief counselor, and the Eye Bank Association of India protocol was strictly followed. Mostly medical legal causes of death like road traffic accidents, suicide, poisoning were considered. Pre-operatively, all the donors were tested for COVID-19, and it was mandatory for the test to be negative. For recipients, careful selection of the pre-operative indications was done, and priority was given for therapeutic and tectonic grafts. All the patients underwent a routine pre-operative testing, and RT-PCR for COVID-19 was done. Post-op visual acuity at 1, 3, 6 months was done, along with analysis for any graft rejection failure was also noted. The analysis revealed a total of 466 eyeballs from a total of 249 donors in the study period, and the average donor age was 62.43 years. Bilateral donor tissues was received from 217 patients, and 32 unilateral was for 32 donors. During the whole timeline, there was complete stoppage of donor activity from April to June, and there was a gradual increasing trend noted from August onwards. This was also observed in similar trends by Das and Almutak et al. There was a study by Balu et al. Which showed a reduction in number of eligible donors also by 45% during the same period. The most common cause of death in our population, during the study period, was cardiac arrest, followed by road traffic accident, hanging, poisoning, and then cerebrovascular accident. The most common preservative method was cortisol in 51%, followed by Macquarie-Kaufman. Glycerol preservation accounted for only 1.5%. The Chaurasia and Lin et al. Have effectively proved the superiority of glycerol preserved tissues in emergency times due to unavailability of fresh donor tissue. The surgical utility rate in our study was 36.4%. The rest of the eyeballs were used for research activities and eyeball training. The main challenge in procuring donor tissue was eliminating COVID-19 as a cause of death. So all the recipients were COVID-19 pre-operatively, and none of them developed COVID-19 actively in the immediate post-operative period. So based on similar studies, as there was no SARS virus detected in the conjunctiva fluid, anterior chamber fluid, and corneal tissues, the COVID-19 donors, there is also a very low risk of transmission due to corneal transplantation. The most common cause for corneal transplantation was therapeutic, and the most common diagnosis was fungal ulcer. Fusarium was the most common species that was isolated in our case. There was a total of 17 graft rejection episodes during this period that we noted. So in the concluding note, eye donation and corneal transplantation can be safely and efficiently carried out even in the midst of an infectious pandemic if proper precautions are taken, and retrospective studies like this help in the long run to improvise on the existing system. Thank you.
Did you do any test in the donor? Any COVID
That's what
test
exactly
in the
I
donor?
wanted to know.
Yes, ma'am. We tested the donors. Pre-operatively, they had to be from the HCRP program, and they were not pre-operative. All the RT-PCR test was done, and it was negative. And they were from a non-COVID ward and non-COVID hospitals.
So
Why did you collect data from Jan 20?
Yes, sir. Actually, the first diagnosed case of COVID came in December 2019. Though
Not
in
in
India,
India.
it was in March 2020. We thought it is better to include the whole of 2020 till the present.
But the first 3 months, Jan, Feb, March, might have influenced also.
Yes, yes, sir. Yes.
did you all stop your eye-banking activities in the lockdown period? Just out of curiosity, I'm asking.
There was complete,
Complete.
It was complete
did stop
stoppage at
also.
that point, and if there was a perforated ulcer, did
ma'am,
you
there were
try
managed.
using cryopreserved, or have you done
Glycerin.
that because glycerine? Because
Yes, ma'am. Actually,
had
that
to
is
do
a
that in
limitation.
Mumbai.
That was a limitation of the study because tissue, T-nonsplasty tissue, fibrin glue, those were patch grafts. Those were not included in the thing.
yeah,
Only
I
eye
think a lot
bank
of
related.
surgeons in Mumbai have used glycerine,
Yes, ma'am.
preserve cornea is for perforated cases.
Yes, ma'am.
Thank you.
Thank you,
Nita,
ma'am.
Can we have our next speaker, Dr. Nisha Rani? Is she there or not there? No? The topic is autologous Steenan's patch graft for corneal perforation, a simple and expensive technique.
Good morning, everyone. My topic is autologous Steenan's patch graft for corneal perforation management, a simple and inexpensive technique. So, corneal perforation is an ocular emergency and requires urgent treatment to maintain globe integrity and to save eye. So, if corneal perforation is small up to 6 mm, we have different techniques to manage. We can do bandage contact lens with glue if perforation is up to 3 mm. We can do amniotic membrane, we can do corneal patch graft, Steenan's patch graft, or anterior lamellar keratoplasty. For large perforation more than 6 mm, we require penetrating keratoplasty or sclerokeratoplasty. So it is a retrospective case series of 7 patients who underwent Steenan's patch graft and study duration was from March 20 to May 21. And medical records were evaluated for demographic data, primary diagnosis of eye and associated systemic disease, for best corrected visual acuity, and size and site of perforation and posterior segment evaluation. So perforation size was made in greatest dimension along perpendicular axis, and perforation are divided according to size into central 4 mm, paracentral 4 to 8 mm, and peripheral 8 mm from the limbus. And for surgical technique, Steenan's graft was harvested from superior temporal quadrant and sutured with the help of 10-0 echelon sutures. And then AC was reformed with the help of air bubble and cyanoacrylate glue and bandage contact lens. No intraoperative complication was observed in any of the cases. It was performed in 2 cases of rheumatoid arthritis and in 5 cases of viral keratitis. 6 cases healed with leukomatous scar formation with preservation of the normal AC depth, and only in one case there is adherent leukoma formation. Then post-op anterior segment OCT was done, and in this figure we can see that tinal patch was properly incorporated into the host corneal tissue, and there is proper maintenance of corneal contour, and epithelium masking was irregular surface was covered with epithelium in 2 weeks. So ours is a retrospective study of 1 year and includes 7 patients, and we take the perforation size cases with perforation less than 4 millimeter, and successful outcome was seen in all cases. Similar successful outcome was seen in similar studies which were conducted in other centers. Thank you.
Thank you, very interesting. Do you have any details on the type of suture that you took while the graft was placed? Was it like a mattress suture? What kind of suturing technique was used?
In paracentral we used interrupted sutures, and for central we used figure of 8 sutures.
Thank you. Thank you. Thank you so much. Can we have our next speaker, Dr. Seema Ramakrishnan? She's talking about revisiting the brave slash.
Good morning, everybody.
Is that her?
The
No.
brave slash revisited. Spontaneous detachment of the Descemet's membrane of the graft following a penetrating keratoplasty is a rare entity. A large or subtotal DMD of the graft can be difficult to manage and may fail despite multiple attempts. We report a technique of draining the pre-descemetic fluid with the help of a venting incision to achieve successful descemetopexy with gas. So the premise, a 29-year-old male diagnosed with bilateral pellucid marginal degeneration suffered acute hydrops in 1992. He underwent a right eye penetrating keratoplasty in 93 and maintained a clear graft, no episode of rejection, and BCVA of 612 till 2019. But in October 2019, he presented with right eye sudden onset fall in vision to counting fingers at 1 meter. Initially, the premise, it looked like a acute graft rejection, and even a pigment line was seen mimicking a Kodados line. The left eye had a PMD. But something was amiss. When we saw the patient, there was, on diffuse illumination of the right eye, showed edema of the corneal graft, sparing only the inferonasal 1/3. So when we deturges the cornea with sterile topical glycerine, as the white arrow shows in figure A, it shows the junction of the attached and detached Descemet's membrane of the graft. The slit image clearly demonstrates the same. So the AIOC2022 also was corroborative, horizontal and vertical images showing the Descemet's membrane detachment. The left eye was showing advanced PMD. So what we did in this case, this patient presented to us 10 weeks after initial loss of vision. So because it was a long duration, we performed a supradescemetic venting incision after debriding the epithelium in the center at the area of the maximum detachment of the DMD. And then we drained the interface fluid and attached the Descemet's membrane with 20% non-expansile SF6 gas. These are the post-operative images, the figure A on POD1, showing the arrow showing the black arrow showing the venting incision, and the 2 arrowheads showing the demarcation line. So after POD8 also, you can see that the graft is now very well cleared, as demonstrated even by the AIOC2022 with attached DMD. So as far as literature search goes, before our case, there have been 6 cases only reporting PKP spontaneous DMD. And out of all these cases, out of the 7 cases, 6 cases have occurred only after, say, around 20 years of the initial PKP. So usually they present very late with spontaneous DMD. Now, considering time to descemetopexy, time to intervention versus success of descemetopexy, patients who presented the first 2 cases 6 and 8 weeks after the DMD happened, they had poor response to descemetopexy and the descemetopexy failed. The case 3, 4 and 5 that were intervened immediately succeeded. Case 6, despite immediate intervention, failed. Ours was the longest time to intervention, 10 weeks, but still our descemetopexy succeeded, most likely because of the venting incision that we created. So to conclude, a high index of suspicion helps us to differentiate and diagnose spontaneous graft DMD from acute graft rejection. And AIOC2022 in this context will really be a valuable tool. And supradescemetic venting incision is a simple but significant addition to the armamentarium of management of DMD, especially long-standing ones, or those that have failed routine tamponading with gas or air. These are my references. Thank you.
What could have been the cause for the spontaneous DMD, etiology?
So this is, the cause is really not known. There is no history of trauma. But the only thing that we are thinking of is that there is a fibrosis of the Descemet's membrane, and there is, these are ectatic cases. So if there is any progression of ectasia, so PMD or keratoconus, and there is a progression of ectasia of the graft, and the Descemet's membrane is contracted in the periphery, it is unable to match with the ectasia progression. That is when it detaches and happens after a very, very long period.
Progression of ectasia and possibly a hydrops kind of thing.
Hydrops, there have been cases in of hydrops occurrence, not exactly a DMD. This is DMD without clear hydrops.
So a simple stroking of the surface and draining out the fluid from the surface along with placing the air bubble, would it have helped rather than giving the venting incisions?
So these cases, now the thing is, this patient had a 10-week waiting period between the presentation and the intervention. The only thing is what happens to the quality of the supradescemetic fluid. It may change in quality. There are more proteins. From an transudate, it becomes more like an exudatish. If it is viscous, it is difficult for it to clear off. As the literature has shown, long waiting period is not helping us with regular decimetopexy, it is not helping the attachment. So that is the reason we decided to drain. That is one thing. The other thing is when these long waiting period can also cause the peripheral margins of this DMD to get fibrosed. So when we are actually tamponading, and if the fluid is not getting drained through the peripheral open area of the DMD because it is fibrosed, it may end up not attaching the DMD, or even sometimes even worsening the DMD because there is no other area of least resistance. So that is the reason why we chose to do the simple maneuver, and we stroked the fluid out completely. As we have, so the important thing is to make the paracentesis only after making the venting incision, so that the DMD is maximally detached. You don't have any risk of puncturing the Descemet's membrane when you are doing the venting incision. And following that, you inject either gas or air, as the case may be, and keep milking the fluid out. It comes out very well. I could not show the video because this is a poster presentation, but you keep milking the fluid out, and at the end of say about 10 minutes or so, all the fluid usually comes out and we can attach.
Doctor, you used air or C3F8?
In this particular case, I have used 20% sulfur hexafluoride, non-expansite.
And how much follow-up you have now on this patient?
This patient, I have 1.5 years follow-up.
And still clear?
Yeah, the graft stayed clear. Only thing is post SF6 probably. He was actually 27 years after PKP. The gas probably has induced, over 1 year he started developing lens changes, and he required a cataract surgery.
Okay, thank you.
Thank you very much.
Our final speaker, Dr. Shrishti Khullar. She should come on time, no? Should we tell her? You tell her. No? Second, once you give her minus marks for that. Came late, yeah. There is no excuse in your doctor.
A very good morning to everyone. I, Dr. Shrishti Khullar, will be presenting on Canada, the emerging threat in post-corneal transplant patients. So the aim is to report the risk factors, clinical characteristics, and outcome of Candida keratitis following corneal transplantation in India, as it has been rarely reported, and studies conducted in India on graft infection post-penetrating keratoplasty have identified coagulase-negative staphylococcus as the most commonly isolated bacterium, and Aspergillus species as the most commonly identified fungi. So we did a retrospective review of medical records of 789 patients who underwent corneal transplant between the time period of April 2015 to March 2020 at 2 tertiary care centers in India. Out of these, 31 eyes developed infectious keratitis, and 5 cases out of these were due to Candida species. So we did further review of the records for these 5 patients for their demographics, the risk factors for graft infection, the indication, number and types of corneal transplant, the time of onset of infection following corneal transplant, the characteristics of infective lesion, the corneal scraping results, the management, and the outcome. The median age of all these patients was between 62 to 71 years, and all 5 patients were male. The right eye was infected in 3 out of 5 cases. 2 patients had keratoprosthesis and rest 3 were pseudophakic. So the most predominant risk factors that we found in our study was repeated corneal transplant, the long-term use of topical steroids, and presence of epithelial defect. And the most interesting aspect to note was variable clinical presentation in all 5 cases, like powder deposit, fluffy white infiltrate, and crystalline keratopathy. Even 2 eyes with keratoprosthesis did not have the same clinical picture. The smear showed budding yeast in all 5 cases, and culture was positive in 4 out of 5 cases. The final outcome after treatment with antifungals was variable. 2 eyes underwent evisceration, 2 eyes had scar formation, and 1 patient succumbed to systemic disease. The number of cases owing to Candida keratitis, as reported in existing literature, is including our study, are a handful, but are on the rise. Repeated corneal transplant and use of topical steroids have been identified the most predominant risk factors in our study, and the contributory risk factors and variation in the configuration was in stark deviation from the existing literature. So to conclude, Candida keratitis following corneal transplant, though unusual in India, seems to be an emerging presentation and can easily be avoided by a timely reduction of risk factors. Since a plethora of clinical presentation are associated with Candida species, it is prudent to have a definitive diagnosis and sensitivity pattern for a successful management. Thank you.
I'm sorry, we have to conclude the session. We don't have time for any questions. I'm done. Yeah. Thank you.
Sorry, I was late. The driver took us through a wrong route.
A very good morning to all of you. I welcome you all in this course on keratoconus, and the idea is that how we are going to make the decision that is important. So I have with me